Postpartum hemorrhage, or PPH, is one of the most serious obstetric emergencies. Defined as the loss of more than 500 ml of blood after a vaginal delivery, or more than 1,000 ml after a cesarean section, PPH is a leading cause of maternal morbidity and mortality worldwide. Now, let's break it down. PPH can be classified into two types: primary and secondary. Primary PPH occurs within the first 24 hours after delivery, while secondary PPH can happen between 24 hours and 12 weeks postpartum. The causes of PPH are summed up as the 4 T's: tone, tissue, trauma, and thrombin. First, tone, which refers to uterine atony. This is the most common cause, accounting for about 70% of cases. Uterine atony occurs when the uterus fails to contract adequately after delivery, leading to excessive bleeding. For instance, a prolonged labor or delivering a large baby can increase this risk. Next, tissue, which involves retained placental tissue. If fragments of the placenta or membranes are left behind, the uterus can't contract properly, leading to bleeding. Patients with a history of cesarean sections are particularly at risk due to complications like placenta accreta. Third, trauma, which includes genital tract injuries such as lacerations, episiotomies, or uterine rupture. Rapid or assisted deliveries using forceps or vacuum can result in significant blood loss from tears. Lastly, thrombin, which covers blood clotting disorders. Conditions like preeclampsia can lead to disseminated intravascular coagulation, a severe state where the blood's clotting factors are depleted. Identifying the signs and symptoms of PPH is crucial. Look for excessive vaginal bleeding, decreased blood pressure, increased heart rate, pallor, cold and clammy skin, dizziness, and decreased urine output. Managing PPH requires a rapid, coordinated response. Start with immediate resuscitation. Secure the airway, ensure breathing, and maintain circulation. Establish IV access for fluid resuscitation and blood transfusions if needed. Administer oxygen, and continuously monitor vital signs, blood loss, and urine output. Pharmacological interventions are also essential. Administer uterotonic agents like oxytocin, misoprostol, or methylorgonavine to stimulate uterine contractions, and consider tranexamic acid to reduce bleeding. If these measures aren't enough, mechanical and surgical interventions may be necessary. Techniques like bimanual compression and balloon tamponade can help control bleeding, and in severe cases, surgical options like uterine artery embolization, vessel ligation, or hysterectomy might be required. Blood replacement through transfusion of packed red blood cells, fresh frozen plasma, and platelets may also be necessary if there's significant blood loss. Nurses play a critical role in managing PPH. They need to frequently monitor the patient's vital signs, blood loss, and uterine tone, and promptly communicate with the obstetrician and team if PPH is suspected. Administering medications, providing emotional support, and educating the patient and family are also key responsibilities. In conclusion, postpartum hemorrhage is a critical obstetric emergency that demands prompt and efficient management. Nurses, by working as part of a multidisciplinary team, play a pivotal role in ensuring the best outcomes for patients experiencing PPH.